Hi, I'm Dan Rubin, back with Ad Hoc with the Doc. Today we're doing it old school style with a single lens. And so I'm here with my good friend and good colleague, Dr. Linda Liu. Dr. Liu is a breast cancer surgeon and a specialist at that. Dr. Liu and I have co-managed patients for several years together. And in fact, at one time, and I think it was more back in the 07 to 2010 days, we actually saw patients under the same roof in the same clinic for a while.
It worked great.
Dr. Liu, Linda, if I may.
Please.
Thank you for being here. Thanks for coming on with Ad Hoc with the Doc. I'm sorry about the little electronic malfunction, but this is great. I'm so happy you're here, and I'm really looking forward to hearing about some of the advances in breast cancer surgery. I know that you also do breast surgery for people that don't have cancer, but specifically for today and how, for the patients that we've seen together, there's a lot going on. There's a lot that I kind of know is happening, but I don't really know the details. And I know we've had a bunch of questions from our patients about genomics and the use of that and sort of decision making for breast cancer surgery. I'm really interested to talk to you and to hear about some of these things. So thank you for being here.
Absolutely, honored to be here.
Tell us a little bit, and tell our audience a little bit how you got, what was your path to breast surgery and then really to subspecialize in breast cancer?
Well, I trained as a general surgeon, so as part of general surgery training, in addition to doing abdominal surgery, we would do breast surgery. And then I always liked it because it had a combination of needing to understand obviously the physiology of it and just the oncology part of it, but also the aesthetics part of it. And then I took a job at the VA, and we ended up having to send our patients elsewhere because we didn't have the radiology facilities to back us up for the lumpectomy. And then when I saw these patients for follow-up, I was a little bit concerned that it wasn't being done as well as it should have been. These patients weren't counseled as well as they could have been. I didn't think their cosmetic outcome was as good as it could have been. So I felt that there was something lacking, and I felt like this is something that I thought that maybe on my little end I could do a little bit better. And
that's why you focused on breast cancer. You went out and you went into private practice.
Right.
And you practice in Scottsdale, Arizona. Correct. Is that your only office site?
Yes, I operate close to you down here in South Scottsdale, but also my main office is up in North Scottsdale.
In terms of decision making, because I do have patients that come and see me and they ask me questions about, should I get this surgery, should I get that surgery, should I have my lymph nodes removed? And quite honestly, that's really not my place in medicine. I don't know the statistics. I don't even know what's included in some of these, especially difficult decision making. And so you are not only a fantastic surgeon, and I know that because the cosmetic results and what my patients say, about how they're treated and the work that you do, but also it's so nice to be able to have dialogue with you. I know patients really appreciate the integrativeness of being able to talk, because the supportive care that I can give around surgeries and the work that we do, whether we're stimulating the immune system or helping to improve healing time or to maybe prepare them for surgery, it's really nice to be able to dialogue. A couple things I wanted to ask you is one, what are some of the advances that you've seen in genomics? Some of the testing that may be done, or does genomics really come into play in your practice?
It does, because I think instead of the old school way where the thought was, it's a cancer, just cut it out, just cut all of it out. Now it's all about being more precise about how much you cut out and having a molecular basis to understand, well, how much do you really need to cut out? Or do you need to rely less on surgery and more, because the information about the tumor says you need to rely more on chemotherapy. So it allows us to really focus on what is the bigger threat and what is the bigger, more important weapon to use, whether it's surgery or chemotherapy or radiation therapy or alternative therapy or just understanding the biology that is more important than us just scraping things out. So a couple of things where I think we really advance more would be, of course, with Angelina Jolie coming out about genetic testing, about finding vulnerabilities that people might have inherited at birth that causes them to get breast cancer. We see a lot more women coming in with genetic testing before they see me and they choose to do a prophylactic mastectomy. Or if a person has not had it before, but they come in with a really small tumor, but they have a striking family history, instead of saying, well, you should do an easy small lumpectomy. If they have a genetic mutation that puts them at risk for getting a second cancer, third cancer, fourth cancer, I'd say you could do a small surgery, but maybe you should do a bigger surgery to prevent that second cancer, third cancer, or fourth cancer. So it helps us define better what we do surgically, but on the other end, also, it also helps us to minimize and not overtreat patients.
That's
Some people feel that because they have family history that they should do a double mastectomy. If I can reassure them and say, look, you don't have a genetic mutation. Yes, you got it once, but it doesn't mean you're going to get a second or third or fourth time. Don't feel compelled to do a double mastectomy.
Because you can tell there's different types of genetic mutations that people can have, and that's what you're talking about.
Exactly.
How they can figure it out.
That allows us to tell us what's the threat that you're going to have this again, which is much more precise than, oh, my family had it, I'm going to get it again and again, and that's not the case. So that helps me, but also helps us to not overtreat patients. So now we do tests like that you mentioned before, oncotype or mammoprint, and that's where we take the tumor and we look at that engine that's driving the tumor. It's kind of like my analogy is you don't really know how fast a car is. It has a nice frame, but you have to flip open the hood and look at it. So oncotype takes the tumor, looks at the engine driving it, and if it's actually a very slow engine, then don't do chemotherapy. So it's allowed us to be more precise in not giving chemo, or giving chemo when we thought, wow, we shouldn't have to. But we've had some patients where we got surprised if they had a really high score and they needed chemo.
Interesting. Really surprised based on their presentation on X-ray or scan and the size of the tumor, or maybe how it looked to you when you were in there trying to get the tumor out. But then when you sent it for testing, it really looked aggressive. So very interesting. I mean, that's really an advancement in medicine, is being able to look at the engine of what's driving it, or what it's built, or maybe even how it got there, is what I kind of hear you saying, is that it sounds like the breast cancer for some people is written in their genes.
Exactly. It's just programmed with faulty wiring.
Some of the mutations are more serious than other mutations.
Correct.
And so I know that there's the BRCA1 and 2 mutation, and then there's the newer one that's starting to look at, I think there's the PALB2.
Correct.
And then what are some other genes that, because I know there's people watching today that are probably getting out their pathology reports or their genomic reports and looking at it and wondering, what some of the other ones are.
So as you mentioned, we used to just do BRCA1 and 2 because we knew that we had more information about it. It was much more common, so we kind of ignored the other ones. But we realized we shouldn't ignore the other ones because we used to be dismissive, but things that are now coming into more importance would be PALB2, CHEK2, RIP1, because now as we're identifying them more, we now realize they're actually a little bit more serious than we used to think. But even if we don't have all that information yet statistically about them, I think patients are entitled to know that the reason they showed up in my doorstep was maybe they had a bad mutation, and maybe that might tip the scales for them to choose a double mastectomy, even if the numbers are not there yet. But we have had changes where before, for example, you mentioned the PALB2, we used to say, no big deal, don't worry about it. But now, as we understand it more, we are now saying some women should consider doing a prophylactic mastectomy for that.
Interesting.
But maybe a couple of years ago we didn't. So that's the whole thing, is that information is so new, we don't know what to do with it, but it will give patients that added information to guide them.
I mean, I think what I hear you saying is that some people think that maybe too much information may be dangerous, and that so often we may see a genomic report that says no clinically actionable variants detected. And when we see no clinically actionable variants detected, that doesn't mean that there's no variants.
Correct.
It just means that of the ones that were detected, none of those we know what to do with.
Right.
Science isn't there yet. What I heard you saying is that we're now catching up. We may find the mutation, and before with the PALB2, we didn't know necessarily what to do, so we didn't know what advice to give. But I think what's also important is you said that people have a right to know that, and a right to know their results. And I may also hear, or maybe I think putting words to this, is that it can be dangerous to go research genomics on the internet without talking to your practitioner.
Exactly, because when you get these confusing results and it's in all this weird medical jargon, you might just get intimidated and lead to the worst case scenario. And when I explain to the patients what these things really mean, it can reassure them that you can still step away and be thoughtful about this and don't panic about this. So I do agree with you that patients have to be cautious when it's a middle of the ground result. Talk to me. but don't look on the internet because you could be led astray into something that maybe isn't the right thing.
Yeah, and especially these N of one stories or people who are blogging who are talking about decisions they made when we don't know that those people made educated decisions in concert with their physician. It's an important. You have a very wonderful and elegant service that you provide to this local Phoenix community. This is a meeting of several physicians that you've grouped together and brought, and you tell us a little bit about this, because I'd love to hear you explain to this, because it's such a great service, and it's a free service, I believe.
It's a free service, and sometimes you come to, or at least we have you call in and get your expertise as well. And so as we know, cancer is not treated just with surgery. It's a team of people. It's you, it's the surgery, it's the radiation, it's the plastic surgery, and it's the radiology, all convening together to give the best recommendations for a patient. But sometimes for the patients, well, I would say the majority of time, the patient has to hop from specialist to specialist and get a really fragmented collection of information. So this is more like, a real-time collaboration, where it's a tumor board, where we have the patient there.
The patient's there.
Which is very unique. Most other tumor boards, the patients just hear about it after the fact, and the panel is convened at a hospital setting. But we actually invite the patient to come. So before we actually have the patient come in the room, we as specialists review the films. We have medical oncology there, radiation oncology, a surgeon, and then a plastic surgeon, because we want to be able to integrate all those in one plan. And we come up with a plan as a group, and then we invite the patient in. And sometimes if you can come, great, or you've called in, you've had a fertility specialist come, and then we present the findings to the patient and explain to them how we came up with this conclusion. But we ask the patient we invite them to participate in the decision making and invite them to ask questions so they feel more involved in that decision making and understand where it came from.
And those are patients that are selected through your practice or a practice from the other physicians in the group?
Correct. That's where they've been coming from, but we want to invite people out in the public, it's people we've never seen before, to bring their cases to us. It's free. They're not obligated to see us, or they can even see our panel kind of a la carte, meaning maybe they want to see you or the medical oncologist but not see me, but it still gives them kind of a group decision or plan.
This is next-gen stuff. This is really helping, patient-directed. This is really trying to drive a personalized N-of-1 plan where there truly is a meeting of the minds and being able to shoot data back and forth and discuss. And the role of naturopathic oncology in this continuum is really is very valuable. I mean, patients who are interested in naturopathic medicine, naturopathic oncology, and who may be going through breast surgery, there's so much that the naturopathic doctor or the naturopathic oncologist can do, especially when they work in harmony with the other parts of the team, whether it be stimulating the immune system or prepping the body before surgery, or helping to heal the body so they can get back to things, get back to exercise, get back to work, provide a better healing, a better scar so they don't have limitations. I mean, I can't tell you how often, the more people, use the tissue after like a breast surgery, because, some people, they tell me they can't, reach, to the top cabinet or something. And so naturopathic oncology can, really help with that, and some of the treatments that we do here at the clinic. What about radiology? Have there been any advancements in the radiology world that helps make breast surgery planning easier or provide a better result? And you had mentioned before, like deciding how much to take out, which I'd love some clarity on that. Does that mean how much of the lesion or how much of the normal breast tissue around the lesion that you look to take out?
So it's kind of both of those elements are important. So no matter what we do surgically, we need a roadmap to tell us, all right, what is the target, and how do we approach it, and how do we minimize excess removal? Before it was just remove the whole breast, but now, like you said, we have great imaging that finds the tumors so much smaller with MRI, with 3D tomo, ultrasound. I like ultrasound, even though it's kind of low tech. It can see through tissue that's very dense. So I'm a big fan of that, even though it sounds like it's very low tech. But since we can see things smaller, it allows us to diminish over treatment of tumors, meaning diminish how much we have to take out, or can see more than we think. Oftentimes on a mammal, we'll see one spot, but the MRI, which is much more sensitive, will show there's a halo or cluster of other ones around it, and that allows us to reach out and grab those as well And it's all about accuracy and information, so you can be more precise. Whether
Precision.
it's limiting what you do or expanding what you do, but still the goal is you have to get the cancer out, but let's not traumatize the patient or give her a bad cosmesis. So we need an accurate roadmap. So we usually do mammo, ultrasound, sometimes MRI, not always.
Okay. Wonderful. Lastly, and last question, because I know you're getting back to practice, as am I. Any advancements in how you decide on how many lymph nodes to sample or not to sample therein? I know that's a big question.
That is a big question. A lot of women are haunted by memories of their aunts or the mothers having horrible lymphedema when they had like 10, 20 lymph nodes removed. So we don't do that operation. That's called a full dissection. Okay. Only rarely do we do that. Generally, we do something called a sentinel node biopsy. Again, more about precision, less invasive. We take out just a few, 1 to 5, and we determine which ones by injecting a special dye, and so it pinpoints for us which to remove. So by removing just 1 to 5, you only have a 6% risk of getting that puffiness in the arm.
6%?
6%. That's 94% that they won't. Mm-hmm. So that's a dramatic improvement over the 20% when they had all the lymph nodes.
Yeah. I don't see as many people coming through needing sleeves or talking about that. I mean, really have been some advancements. So I'd love to close just by telling you how much I respect your work. I respect that you interface with me and dialogue with me. I feel honored to be able to share patients with you and that you trust the work that we do. This is Dr. Linda Liu, a Scottsdale-based breast cancer surgeon. Meticulous work, a real doctor treating real people in real time, and thank you for being here.
Well, thanks always for entrusting your patients to us, so we appreciate you helping our patients to get through their conventional treatments with naturopathic.
Thank you.